thank you for the short and nice introduction. And I would like to thank the committee for inviting me as well to talk to our juniors today. I hope that I can deliver what I know and can share my knowledge with all of you here today. Okay, let me share my screen. Okay, you can see my screen now. So what I'm going to talk to you all about today is lymphoma, in particular in a Trephine biopsy. Okay, how do we detect them? How do we look at them? And how immunohistochemistry can help us to identify and classify try our best to classify the lymphoma that we see in the Trephine. Okay, before starting talking about lymphomas, I think I will go through some brief intro about Trephine biopsy. Okay, and what are the normal things? Because we cannot talk about something abnormal before knowing what is normal, right? So what are the advantages of doing a Trephine biopsy over aspirate? And first of all, by looking at Trephine, it enables us to examine the topographical distribution of the cells, different components of the cells in the marrow, okay, and to relate this hematopoietic component to the surrounding bony trabeculae, because this will give us a lot of useful information in our diagnostic work. Okay, and of course, the best place to assess marrow cellularity is still the Trephine, despite I know we can still assess the cellularity in the marrow from the aspirate smears, but the best one is still, I would say, is still in the Trephine if you can get a very nice Trephine course. Okay, and Trephine biopsy will be, of course, especially useful when the aspirate fails to give you an adequate sample. For example, in patient, if the marrow is very fibrous, so our clinician cannot suck out enough marrow for us to do the smear. All right. Okay, lymphoid infiltrates in the bone marrow Trephine biopsies, okay, are commonly encountered as part of a diagnostic work, okay, in our daily work, and especially for staging workup, okay, for lymphomas. Or sometimes it can be seen as an incidental finding in a sample taken for other pathology, right? But in the minority of cases, okay, when we don't have anything else but only the Trephine biopsy, so this may be the only sample that we have to for a diagnosis of a lymphoma. Okay, and first of all, before evaluating what is abnormal, okay, we need to understand what is normal, okay, in a Trephine biopsy, core biopsy, and what are the permissible within normal. All right, if you see something slightly abnormal, are they still acceptable as a normal? So these are the variations we need to know before we call it abnormal. Okay, let's go through the normal bone marrow briefly. Okay, first of all, bone marrow is not a random mixture of different type of bone forming cells, and this is what as I'm talking as from a histopathologist's point of view, because a lot of us, we are so used to looking at other organs. All right, when we come to look at the Trephine biopsy, because we are not familiar with them, and there are a lot of round cells around, that's all we see. That's why for a histopathologist's point of view, we are kind of a bit comprehensive when looking at Trephine biopsy. But bear in mind, all right, it is a very highly organized and specialized tissue, as in any other tissue we can find in the organ of our body. Okay, but the morphology of these individual cells in the Trephine biopsy, of course, is not as precise as we see in an aspirate smear. Okay, by talking to the hematologist here, I'm sure you all can appreciate what I mean clearly. Because in aspirate smears, we actually can look at the individual cells clearly. We look at them one by one, right? And we criticize their morphology, every individual cells individually. And for the histopathologists, we look at the overall structure. That's why we start looking at slides from a very low power, because we want to appreciate the overall morphology. Okay, and in fact, we don't use high power objective very often to look at individual cells, because the overall morphology, the overall histomorphology is more important for us. All right. Whereas and again, I bring back to here in a Trephine. Okay, it's very hard to appreciate the individual cell morphology, as you can see in the aspirate. Bear that in mind, keep that in mind. So what helps us to differentiate this marrow cell population is by identifying who are the friends, all right? The nearby friends. I will tell you in detail in the next few slides, all right? Because by looking at who are staying around them, who are keeping this cell company, okay, it can help us to differentiate this group of cells. And of course, by using immunohistochemical staining and some other special stains. Okay, how to be confident in examining a Trephine biopsy when because you might not be seeing a Trephine biopsy very often. Okay, it is by, of course, I want to emphasize again, be familiar with the normal marrow appearances, okay, and understand how this changes throughout life, right? Okay, the site of hematopoiesis in normal adults, okay, are in the skull, the sternum, the vertebra, the ribs, pelvis, and of course the proximal regions of the long bones. But the most accessible one where we normally do our bone marrow Trephine from is from the pelvis. Okay, what are the components of the normal bone marrow Trephine? First of all, let's look at the bone. Okay, the bony trabeculae in the Trephine biopsy consists of lamellar bone. There are many types of bone, but in here particularly are lamellar bone. Okay, these bones are surrounded by osteoblasts, okay, along the outer surface of these bony trabeculae. Okay, be careful that these osteoblasts can look very similar with plasma cells. So how do we differentiate them? Okay, if you see enough of them, you will be able, the normal plasma cells, everybody knows that they have the nucleus is eccentrically placed, where osteoblast, of course, you can say is also eccentrically placed, but look at the nucleus. Okay, we always talk about clock phase, appearance of the chromatin pattern in the nucleus. So these are, and of course, the color of the cytoplasm will help us to differentiate between these two cell types. Okay, and of course, the location of these cells. Okay, the osteoclasts are also present along the endosteal surface, and they have 4 to 6 nuclei. All right. Okay, the stroma of the bone marrow consists of the vessels, the reticulin, fibroblasts, fat, and iron. Okay, when we look at the vessels, all right, in the normal bone marrow, the sinusoids, the venous sinusoids are normally collapsed. That's why they are not easily identifiable. All right, as those seen in like a myeloproliferative neoplasm, they will be dilated and become very prominent. But in a normal marrow, it's very hard to detect them. All right, and then remember I talked about the location and the friends of a different type of cells. All right, for mature megakaryocytes, they are often seen close to or right next to the thin wall sinusoids. Remember, if you see the megakaryocytes, try to identify the collapsed sinusoid beside them. All right, they are not very obvious, but if you look close enough, you will be able to appreciate them. Okay, and those small arteries with the thicker muscle wall, all right, normally the granulopoietic element will be seen very close to them, right? And plasma cells like to be close to the small capillaries. Right, so these are the landmark that help us to identify. That's why I said earlier on. Okay, it's a very highly specialized and structured tissue in our body, the bone marrow. Okay, reticulin and fibroblasts form part of the stroma of the bone marrow. Okay, normally in a normal adult marrow, we have very little reticulin, and you don't see fibrosis. All right. And these reticulin are produced by the elongated fibroblasts, okay, and they exist in a very fine network and distribute evenly throughout the marrow, okay. Of course, in a normal marrow, they will be slightly more dense, okay, and more obvious around the vessels. And be careful, crush artifact introduced by the procedure when obtaining the bone marrow trephine biopsy will cause smearing, okay, and pooling of the cell nuclei, and it will morphologically will look very similar with fibrosis. So if you see the whole, you look at the overall trephine, all right, you see a lot of crush artifact, and you think, hey, could it be fibrosis or because of the artifact? All right, be careful and use a reticulin stain to help you to differentiate them. All right. Okay, fat. The amount of fat in the red marrow, okay, increases with age. Okay, as we age, our marrow get less cellular and we have more fat in the marrow spaces, right? And of course, the subcortical region from our pelvic iliac crest, okay, have a greater percentage of fat as than the deeper regions. That's why when we want to look at the cellularity, assess the cellularity of the marrow, right, we don't look at the subcortical region. We will omit the first 2-3 marrow spaces, right? And we look further down to assess the cellularity, because this region is normally low in cellularity. So if we look at this region to assess the cellularity, okay, your patient marrow will be, most of the time will be hypocellular, or even you might call it aplastic, because there's hardly any cells there. All right, so these are the normal variations that we have to bear in mind. Okay, and there's another thing we call first fat space, all right, which is you can see the bone trabeculae, then it's lined by a layer of osteoblasts. Then there will be a single layer of fat cells that we call the first fat space. In a normal marrow, this fat space is retained. If you look at it and you have your patient's marrow have a loss of this first fat space, which means something abnormal is going on in the marrow. Okay, it's very hypercellular until you lost this fat space. It is a useful sign of early neoplastic changes, such as in the MPN or MDS, right? Okay, let's look at the hematopoietic tissue. Okay, first we start with the granulocytic series. Okay, the immature forms of the granulocytic series are arranged along near to the surface of the bone. Okay, and they mature as they move to the central intratrabecular region. All right, and a similar arrangement can also be seen around the small vessels within the marrow, which means when you see the small vessels, those cells around them will be tend to be the more immature forms. As it moves away from the vessels, so it becomes the more mature forms of the granulocytic series. Okay, and of course, the eosinophil precursors can be easily distinguished from the neutrophils precursor by their very red and coarse granules. And the normal adult marrow has a ratio of granulocyte to erythroid of about 2:1. Okay, but remember the normal variation throughout different stages of our life I mentioned earlier. So in here, the first few weeks of a newborn, okay, this ratio, the granulocytic to erythroid ratio of 2:1 is reversed. All right, with up to 70% of cells can be of the erythroid series. Okay, mainly the pro-erythroblasts and normal blasts. So you got to adjust your mind a bit when you look at the marrow from a young babies. Let's go to the red blood cell series, the erythroid elements. Okay, they are normally organized in small groups. All right, and they are not near to the bone, they are in the central regions of the marrow spaces. Okay, and these erythroid islands, okay, will consist of the whole series of erythroid elements, okay, from the early pronormoblast throughout to the normoblast, okay? And some people may say, it's difficult for me to differentiate whether these are the erythroid precursors or lymphocytes, aggregates, right? One thing that will help us is the macrophage. Okay, it's usually, if you see this island, normally in the center, you will see a macrophage in the erythroid islands. So if you see these features, this will help us to differentiate whether, if you can't differentiate them, the erythroid from the lymphoid cells. And of course, the erythroid cells will have, because of the processing, the artifact caused by processing of the marrow, the trephine, you will tend to get a clear halos around the nucleus of this erythroid series. And another thing is the erythroid series, the erythroid elements will have a very rounded nucleus and very dense, very dark blue type of nuclear chromatin as compared to the lymphocytes. All right. Okay, now let's go to the mega series. Okay, the megakaryocytes are usually found distributed uniformly throughout the marrow spaces. Okay, without forming groups. Okay, groups or very close to each other. Okay, they should normally they stay away from each other. They have their own personal space, we call that. Okay, if you see a group of megakaryocytes staying close together, or they are staying close to the bone, beware, this is a sign of abnormality. Okay, now let's go to lymphocytes, which will be our main character, this one that we want to talk about today. Okay, in normal adult marrow, okay, this population of lymphocytes can consist of both B and T cells, and they are usually inconspicuous. They are not very obvious, and they are distributed throughout the marrow, right? Usually the T cells will be slightly more than the B cells in the marrow, okay? And these cells are small, all right? And they are separated from each other, okay, and distributed evenly, all right, throughout. They might form small aggregates or small nodules, all right? But these nodules, lymphoid nodules, normally they are not close to the marrow, the bone, sorry. Okay, they are in the center of the marrow spaces. Okay, and of course, variations as in different ages, these lymphoid aggregates tend to increase in number with age, which means if this is an elder adult marrow, if you see lymphoid aggregates in them, okay, don't worry, it's fine as long as it's not more than 3 lymphoid aggregates per trephine. All right, if you see 1 or 2 of them, they are quite normal. But if you do see lymphoid aggregates in a pediatric trephine biopsy, all right, beware, this is abnormal. Okay, now, how do we differentiate, okay, whether these lymphoid aggregates, okay, we talk about the number permissible within normal, but morphologically, there are certain things that we can help us to differentiate whether these lymphoid follicles are benign or neoplastic. Okay, first of all, okay, the benign one tend to be more rounded, where the neoplastic aggregates will be irregular. Okay, and the components inside the lymphoid aggregate, in the benign lymphoid aggregate, okay, you see small lymphocytes with kind of regular nuclei, whereas you look close, okay, the neoplastic aggregate will have lymphocytes that show atypia. All right, like I said just now, as we age, we tend to get some benign lymphoid aggregates. All right, while wide age range is seen in the neoplastic, we can't tell. And the size might help. Normally, the benign lymphoid aggregates are very small. Okay, when you see big lymphoid nodules, okay, these are abnormal. And of course, the location again, all right? A normal lymphoid aggregate, okay, will not stick to or stay very close to the bony trabeculae. All right, if you see them like a very adhesive, like right next to or adhered to the or wrapping around the bony trabeculae, these are abnormal aggregates. All right, and the abnormal aggregates normally don't show presence of germinal centers, where the benign one, because they're usually reactive. So in a very small amount of cases, if you're lucky enough, you might be able to appreciate germinal centers, right? And the benign aggregates contain a mixture of other lymphoid cells, for example, plasma cells and eosinophils, whereas the abnormal one, okay, you will just see lymphoid cells with nuclear atypia, and they are irregular. And of course, the light chain expression will help us to differentiate, okay, and the number of aggregates per trephine. Okay, now let's move to plasma cells. All right, plasma cells are quite easily identifiable in normal adult marrow, and I'm sure every one of you by now will know how plasma cells look like, because their size are bigger and they have abundant cytoplasm, which is like they have a special kind of a bluish color, so it's easy to recognize them whether they are in the aspirate or in the trephine. All right, shouldn't be a problem. And normally, they constitute about 2% of the cell population in the marrow. And again, most of them occur singly or in a small 2-3 cells group. All right. If you see diffuse and a lot of them in the marrow spaces, these are abnormal as well. Okay, this is the cellularity that I mentioned earlier. If you look at this area, okay, if you cover this area up, all right, you just look at this area. If you assess, this is the subcortical region. If you assess cellularity of the marrow based on these few marrow spaces, okay, without looking further down of the biopsy, okay, your comment will be hypercellularity, right? Or even call it aplastic, because you hardly see any hematopoietic tissue here in the subcortical region. So it's very important for us to go further down. And if the core biopsy, the length is not sufficient, okay, you have to mention it in your report and alert the clinician, hey, look, your core is not long enough, your core is not deep enough, so I cannot, I say it's slightly hypocellular here, but it might not be representing the whole picture. So have to warn them, okay? And looking at this picture, okay, the cellularity is different age, okay, will have a different cellularity, different amounts of fat cells in the fatty tissue in the marrow. So we normally take 100 minus the age of a patient. For example, if a patient is 60 years old, 100 minus 60, so the cellularity, the normal one will be about 40–50%. All right. Okay, I already mentioned this one earlier. Okay, before I go into the different type of low-grade lymphoma in the marrow, okay, I will go through briefly about how do we assess the lymphoid infiltrate if we encounter them in a trephine biopsy. First of all, the cellularity, okay? Differentiate, when you look at it, oh, the trephine is very cellular, something abnormal is happening, okay? It appears very blue. What are these cells? All right, first of all, try to differentiate which are the normal hematopoietic cell lines, all right? Which are the erythroid, which are the granulosity, where is the megas, and the lymphoid cells, separate them up in your mind. All right, then you assess whether the cellularity is the whole marrow cellularity is normal, increase, decrease. You can even estimate the numbers, the cellularity. Okay, the lymphoid infiltrate again, the architecture. Where are the locations of this lymphoid infiltrate? All right, okay, whether they are interstitial, interstitial in the marrow spaces, whether they appear in aggregates, nodules, or they are diffusely distributed, whether they are next to the bone, bony trabeculae, whether they are inside or outside of the sinusoids or the vessels, or it's a mixed pattern sometimes. Okay, and the size of these lymphoid aggregates, okay, and bear in mind that there's no fixed criteria to assess size. Although just now I show you less than 3 mm, more than 3 mm, some studies do say that, but actually there's no consensus, no fixed agreement about the size. All right, the terminology is quite subjective. We use small aggregates or large aggregates, okay, and of course you can give more specific assessment. Okay, the number of in the infiltrating cells can be expressed in percentage of total nucleated marrow cellularity, TNC. Okay, lymphoid infiltrate. Look at the cytology, the size of these lymphoid cells, whether they are small or large. If they are small, like for example in the CLL, all right, and large, typically in high-grade lymphomas, they tend to be large, okay? Or it's a mixture of small and large cells. For example, follicular lymphoma, okay? You can have a mixture of small and large cells. We will go through it later when I talk about CLL, follicular lymphoma, why you can get a mixture of small and large cells, okay? And then mantle cell lymphoma, okay, or cases with a mixture of low-grade and high-grade component. For example, CLL with Richter transformation. So you can get a combination of small and large cell together. Or follicular lymphoma with diffuse large B-cell lymphoma, or even a mantle cell lymphoma with a blastoid morphology. So they will give you a mixture of small and large cell in this type of lymphoma. And look at the cytoplasm, okay? The amount of cytoplasm in these lymphoid cells, okay? Their staining characteristic, the texture, the position of the nucleus in the cytoplasm, whether they're in the center or eccentrically placed, all right? And in the lymphoid cells, most of the time, the cytoplasm is very scanty or negligible, all right? And if they are there, they're scanty, and it gives you like a bluish appearance, okay, on a low power. Okay, if the amount of the cytoplasm is moderate, okay, this might be cells with plasmacytic differentiation. They tend to be more, they have more cytoplasm, right? Okay, and they have when you look at on low power, you look at the Trephine, they are not as blue, right? They tend to be more pinkish because of the more amount of cytoplasm. Cytoplasm is a bit pinkish, right? And of course, this coloration will depends on your local lab staining preference. You know, some lab they have a darker blue tinge, and some lab tend to be more pinkish. So you have to adjust accordingly. Right? You adjust your eyes accordingly to your local lab setting, the staining setting. Okay, now look at the nucleus of these lymphoid cells. Okay, the size. Okay, the contour, whether they are regular or irregular, whether the chromatin is open, closed, salt and pepper, all right, or mud cake appearance, all right, and the presence or absence of nucleoli. If they are present, how many of them, whether they are one big, very prominent nucleoli, or they have multiple small nucleoli. Inclusions body, like Dutch's bodies, all right, the mitotic activity in the cell, and whether there's apoptotic bodies. And at the same time, don't forget about the background marrow changes, all right? And any other pathology, okay, that comes with a lymphoma, like hemophagocytosis, whether there's granulomas, fibrosis in the background, right? Okay, when you are assessing a bone marrow biopsy with suspected infiltration of malignant lymphomas, okay, what has to be considered? First, of course, you have to decide whether there is abnormal infiltrate or not, positive or negative, all right? This is normally for staging marrow, all right? Okay. Subtyping of the lymphomatous infiltrate, okay, if you can, okay, subtype it according to the WHO classification, the infiltration pattern, okay, the extent of the infiltration, okay, by percentage of the area involved or by the percentage of nucleated cells, all right? And assess the residual hematopoiesis in the background, all right? The bone structure, all right, whether there's increased remodeling, thickening of the bone, okay? And if this is a post-treatment Trephine, okay, you assess the response to therapy, all right? And for lymphoma, small low-grade B-cell, low-grade lymphoma, you want to assess whether there's transformation to a higher grade of lymphoma. So these are the things we want to look at when we are assessing lymphoma in a bone marrow. Okay, these are the different pattern of distribution, like this one, lymphoid aggregate in the marrow, in the center of the marrow spaces. All right, this one is the nodules, like close to or like a stick on to the bone, and they can be in linear form as well. right? This one is intrasinusoidal, okay, in the sinusoids. Okay, this one is interstitially distributed in the this one in the marrow spaces, interstitially distributed. Okay, it come in irregular large nodules, right? Or diffusely infiltrated and filling jam-packed the marrow spaces. Okay, now let's move on to low-grade lymphoma in the bone marrow trephine. Okay, the first low-grade lymphoma I'm going to talk about is CLL, chronic lymphocytic leukemia. Okay, by going through what are the normal normal morphology that we expect, and what are what to assess and what are the abnormal infiltrate looks like. So now when we talk about the different type of lymphoma, it will be easier for us to understand what we want to assess. Okay, CLL is typically seen in the elderly patient. The average age that they present is about 65 years old. Okay, and bone marrow biopsy is not necessary for the diagnosis because most of the time, by clinical presentation, by looking at the full blood count, okay, by assessing the peripheral blood smears and the flow cytometry, we already have a diagnosis, right? But the trephine biopsy will still be useful to assess, okay, the pattern of the involvement in the marrow and the extent of the bone marrow involvement, all right, how extensive it is, right? And of course, post-treatment, we can assess the residual, not post-treatment, and at the same time, we want to assess the residual hematopoietic tissue, right, as a baseline before we start treatment. The CLL cells are usually small, okay? They have very dense chromatin and very scanty cytoplasm. Okay, if you ask me, if an inexperienced eye, okay, they can look very normal to the normal small lymphocytes. All right. So by morphology, we have to assess them to tell us whether they are normal or abnormal. Okay, CLL may form the abnormal lymphoma cells may form nodular proliferation center, okay, which is very unique to CLL. And these proliferation centers are made up of small regular lymphocytes, right? Scattered pro-lymphocytes, which are slightly larger than the lymphocytes, with clump chromatin, very dark chromatin, nuclear, and a small nucleolus. And scattered para-immunoblasts. These para-immunoblasts are larger cells with more opened nuclear chromatin, okay? And they tend to have a very distinct, large central nucleolus, right? This is these cells are forming the proliferation center. So on low power, the proliferation center tends to be slightly lighter than the surrounding abnormal lymphoid infiltrate of the CLL cells, all right? Okay, the pattern of bone marrow infiltration may be useful to help us to distinguish between CLL from other type of lymphoma. Okay, infiltration patterns can be focal, but bear in mind they are always non-paratrabecular nodules, right? Or they can involve the marrow spaces interstitially, all right? And tend to like mix with the surrounding normal hematopoietic elements. Or sometimes they can come in a diffuse, like a jam-packed lesions if there's a extensive involvement of the marrow scene, okay? Sometimes in the one single core biopsy, you can appreciate multiple patterns, right? And again, I want to stress that they are usually not paratrabecular in distribution. Okay, this is a marrow core biopsy from a patient with CLL in a nodule form, right? They are far away from the bone, the trabeculae. They are not like sticking onto it, like close to it. Okay, look at this as compared to surrounding normal hematopoietic tissue, right? You should be able to appreciate them on low power because these infiltrate appear dark blue, right? It will catch your eyes when you are doing the screening of the trephine. Okay, and these cells tend to be small, right? Okay, higher power. Okay, you see, they are slightly irregular, the nucleus, slightly irregular, okay? And there's abundant preserved megakaryocytes within this infiltrate. Okay, immunoexpression of CLL cells. Okay, the neoplastic infiltrate express pan-B markers like CD20, CD79A, CD19, and PAX5. And at the same time, they also co-express CD5. But if you compare this, because CD5 is actually T-cell markers, but these were in the two type of lymphoma cells, okay, CLL, chronic lymphocytic lymphoma, and mantle cell lymphoma, the B cells will have aberrant expression of CD5. So when you look closely, the CD5 expression of this abnormal lymphoid infiltrate in this B cell lymphoma tend to be weaker than the background normal T cells. Okay, and these cells, the neoplastic CLL cells, also express CD23. Okay, and this pattern can be appreciated in you can already see it before you look at the Trephine, because normally Trephine comes in days later because of the processing, cutting, right? By the time you already have your floor in hand, right? So in your floor, you already can tell, oh, there's an abnormal population of B cells which express CD20, 19, PAX5, and they also express CD5, which is dimmer, and they express strong CD23 and very bright CD200. So most of the time, you already have the diagnosis in hand. Okay, and proliferation centers, if you can appreciate the proliferation, slightly lighter proliferation center on low power, okay, do a cyclin D1. This proliferation center will tend to have a weakly positive cyclin D1 expression. Okay, and IHC is very important to help us to assess, especially in a post-chemotherapy patient, to reassess the marrow. It will help us to differentiate between reactive lymphoid nodules and whether there's a residual neoplastic infiltrate in the marrow. Okay, H&E stain. This is the abnormal lymphoid infiltrate, all right? These are like small, from low power, we can appreciate that they are kind of small, all right? Lymphoid cells, right, with very scanty cytoplasm. That's why they look bluish, okay? And these cells express CD19 B markers, CD20, okay? And they are also strongly positive for CD23, which is very specific for CLL as well. They express CD5, okay? And you look at this one, CD3 is negative, okay? Of course, you get some normal CD3 positive T cells scattered, right? But they're not diffusely staining this aggregate of cells. And the Ki-67 proliferative index is low. Okay, don't look at this area. This area is the normal hematopoietic tissue, and we expect high proliferation rate in the normal marrow, right? Look at the lymphoid infiltrate, the lymphoid infiltrate here, the bluish here. That's why the counter staining, in histology, we call this bluish stain, the light blue stain, as a counter stain. So we want to look at the morphology when we are assessing the immunohistochemical staining, because we want to know, imagine without this blue stain, you can only see the brown dots everywhere. So we don't know what are these what cells are these brown dots staining, right? So we need the counter stain to help us decide, oh, okay, now I want to assess this lymphoid infiltrate. So the proliferative index Ki-67 is kind of low in this area. Okay, don't look at this area. Okay, okay, and in CLL, sometimes you can see increase in interstitial lymphocytes, okay, and mixed with hematopoietic ligaments, and they tend to have reduced in residual erythropoiesis and myelopoiesis, but relatively preservation of megakaryocytes number, like as we see earlier here, right? In this abnormal infiltrate of CLL cells, they tend to have a normal number of megas, but there's reduced erythroid and myeloid elements. Okay. Okay, it can, we need to assess the biopsy marrow for CLL patient as a baseline test before we start treatment. Okay, and also post-chemo, okay, you need to look at it to assess the response to therapy. Okay, the second low-grade lymphoma that we can see in the Trephine biopsy is mantle cell lymphoma. Okay, bone marrow infiltration occurs in about 50 to 90% of patients with mantle cell lymphoma. Okay, it is detected more frequently in core biopsies than in S-grade somehow, okay? And the pattern of infiltration can be nodular, interstitial, or paratrabecular, okay? With most of the time, we see a combination of these patterns of infiltration. Okay, cells in mantle cell lymphoma, they are kind of monotonous, all right? They are small to intermediate in size, right? If you look closely enough, the nuclei are not as rounded as the normal lymphocytes. Okay, they tend to be slightly irregular. Of course, they have mature B-cell markers phenotype like CD20 is positive, CD79A is positive, CD19 and PAX5 are positive. And remember, I mentioned just now there are two types of small B-cell lymphoma that co-express CD5. One is CLL, the other one is mantle cell lymphoma. And how to differentiate CLL and mantle cell lymphoma? If you see CD45 lymphoid infiltrate, do a cyclin D1, because cyclin D1 will be positive in mantle cell lymphoma and negative in CLL, and CD23 is positive in CLL and negative in cyclin D1 in mantle cell lymphoma. Okay, of course, be careful as well. Some mantle cell lymphoma do not express cyclin D1 in a very small percentage of cells. So we have another markers to help us. It's called SOX11, all right? Okay, like I say earlier, you can have like a mixed pattern of distribution of this abnormal lymphoid cell. Okay, it can be paratrabecular, okay, next to or very close to the bone, right? Paratrabecular. This one is the abnormal infiltrate here. Whereas here, the less cellular area, these are the normal hematopoietic tissue area here. In here, see, it's like very close, thin strips only, but that's why the assessment is very, you got to be very careful. You look at this picture, okay, the abnormal infiltrate is like in a thinner strips, whereas here it's thicker, so easier for you to recognize them. And in this picture, it's more diffuse, all right? Do immunostains on them. You can appreciate then the abnormal lymphoid infiltrate in the paratrabecular location. They are CD20 positive. Again here, okay, and these cells, okay, are CD5 positive and cyclin D1 positive. Right, this one closer view. And of course, be careful with cyclin D1 as well. Okay. Cyclin D1 is not only positive in mantle cell lymphoma, it can be positive in hairy cell leukemia as well, which is not a very common leukemia. And, okay, this one have to be very careful. I said just now, CLL is normally negative for cyclin D1, with the exception that in the proliferation center of CLL, right? The proliferation center of CLL, remember just now I mentioned on low power, you tend to see like a nodules of slightly lighter staining. If you zoom in, you can see this center, these nodules is composed of small lymphocytes, pro-lymphocytes, slightly larger cells, and para-immunoblasts. All right, and we call this proliferation center. And this proliferation center, again, can be positive for cyclin D1, but the staining is very faint. All right, it's not as strong as diffuse as cyclin D1 positivity that you see in mantle cell lymphoma. Okay, and also in plasma cell myelomas, cyclin D1 will be positive as well. That's why, and I think I cannot emphasize more. Okay, the assessment of lymphoma, you got to put in the clinical features, the clinical presentation, okay, the histomorphological features, okay, then you have to add add on the immunohistochemical expression. You have to put all this information together when you make a diagnosis of lymphoma, right? You cannot be solely, it cannot be so rigid. Okay, cyclin D1 must be positive in mantle cell lymphoma and no other else will be positive. No. Usage of immunohistochemistry staining is not like that. You've got to be very careful. There's always aberrant expression. Okay, there's always other fangs who can express them, you see, like this one, but the staining pattern might be different. So we have to, when the assessing all these immunostain, we got to put in all the information that we have, okay, and use this information wisely to come to a correct, most accurate diagnosis. And of course, the vessels, the endothelial cells, those cells that line the vessels, all right, are also positive for cyclin D1. And we always use this as our internal control. When we assess the marrow, okay, we want to look at the vessels. If they also pick up cyclin D1 and the infiltrate is negative, we know that it's fine. This is a true negative because the endothelial cells, the normal internal control, they are picking up. So my stain is working. Okay, nothing much in this one. I'll skip. Okay. Sorry, I'm going everywhere. Okay. Something that I want to highlight here, right? You look at this nodule, right? This is what we call like a germinal center, the nodules, right? Can you appreciate this one is slightly lighter on H&E staining, right? Okay, if you look close enough, you can see the different type of centrocytes and centroblasts with what tingible body macrophages in the germinal center, and this germinal center is we call it a reactive lymphoid this one aggregates, and they are surrounded by darker mantle zone. All right, mantle zone. If we do a CD20 stains, the B markers, they are positive. All right, and CD23 here, CD23, we're not talking about CLL. This is another usage of CD23. They normally stain the follicular dendritic cells, okay, in a lymphoid follicle center, right? This is the whole lymphoid follicles, all right? This is the darker zone, they are negative, all right? And these germinal centers, they have a very concentric network of CD23 positive follicular dendritic cells. Okay, we do a cyclin D1. Okay, cyclin D1, instead of staining the whole lymphoid aggregate, it only stains the mantle zone here. All right. Okay, and BCL6 and CD10, okay, only stain the germinal center. The site here is negative, and the proliferative index Ki67 is denser in the germinal centers. All right, this looks like a normal lymphoid follicles, right? With a reactive germinal centers, right? A kind of reactive kind of pattern. But bear in mind, again, what catch my attention is because the location in a normal lymphoid aggregate, okay, you don't get the paratrabecular type of location. The bone is here, and the lymphoid aggregates, okay, having a reactive type of immunoexpression, but the location is not right. All right, it's right next to the bone. So be careful. Okay, this is what we call an in situ mantle cell lymphoma. Okay, it is very rare. Okay, normally we see in lymph nodes, but can be found in biopsy as well, Trephine biopsy as well. I just want to introduce you to this. Just be aware when you look at the lymphoid aggregates. All right. Okay, they can have a very normal looking follicles. All right. Cyclin D1 will help us to reveal them as abnormal lymphoid aggregate. Okay, because the cyclin D1 positivity, instead of staining the whole lymphoid follicles, okay, it will stain the mantle zone only. But of course, this type of mantle cell lymphoma have a very indolent behavior. Okay, normally we don't need to start treatment for this. the clinician will keep watchful eyes on them, all right, and just follow up them up closely. Do you all need a break? Because I'm going to, my lecture is for 2 hours. All right. I'm actually the next one, the high grade one might not be as long as the low grade one. So maybe I can just give you a break for a while. And we have talked about the normal pattern, the abnormal pattern of lymphoid infiltrate in marrow. I have gone through CLL and mantle cell lymphoma. All right. I think we can stop for a while here. Right. If you have any questions, you can ask me. Then we take a short, like a few minutes break before I continue with the rest. Is that okay?
Okay, Doctor.
You guys have any question? Or am I going too fast or too lengthy? Or repeating too many same things? You have to let me know. You can let me know here.
Hi, Dr. Ivy, Dr. Nick here. I'm back. After Niyat, to the audience, do you have any questions to Dr. Ivy? Is everything crystal clear to you all? How long do you need, Dr. Ivy, for the break?
Maybe we take a 5 minutes break. Is that okay?
Yeah, sure. Okay, we take a
If
5
I
minute.
keep on talking for 2 hours, I think everybody will be bored as well.
Yeah. Okay, I
So we
agree.
take a
Okay,
5 minute break.
Yeah, that's good. Okay,
Okay.
5 minutes break from now. Yeah. All right.
Okay.
See you in 5 minutes time. Thank you.
Okay, thank you, Doctor.